Thank you for being here. Yes, and I'm going to talk to you today, as we discussed, about the Brompton Hospital and our major hemorrhage protocol. So this is our hospital. It's based in London, in the heart of London in Chelsea, which has been made famous for made in Chelsea, but for other reasons as well. And it's a lovely place to work. And our branch of the Sprint programme is within the Paediatric Intensive Care Unit. And we call ourselves a Sprint programme because we are a simulated interprofessional team training programme, and we run weekly in-situ simulations. Just to give you a feel about our hospital, so we have over 500 admissions a year to our Paediatric Intensive Care Unit, and the majority of those are infants and children with congenital cardiac lesions requiring cardiac surgery. So as I mentioned, we run high fidelity in-situ sim. It's interprofessional, and by that I mean that we have a multitude of people participating in our weekly in-situ sims, doctors and nurses, as well as allied health professionals. And we've trained over 2,000 professionals over 11 years in 305 in-situ simulation sessions. So it's a very well-established programme which the hospital management is been pleased with for many years. And as part of our programme, we have identified multiple latent threats over the years and have worked with the patient safety department to register those as datexes where needed and to work on them with the patient safety department. We also have a kind of sideline in developing mannequins and have got some success in that. So just to give you a feel for that, this is our Tom mannequin, which we can do a realistic open chest scenario, allowing post-cardiac surgery emergency restenotomy to be simulated. And this has really helped us to engage all of the teams that work in the Brompton, including our consultant cardiothoracic colleagues. And here is a more low fidelity sim, but hooked up to an ECMO machine, which we have used again to simulate open chest requirements post-cardiac surgery. And we have a new mannequin due to come out next year as well. So I'm going to talk to you just a little bit more about major hemorrhage. So it's a leading cause of cardiac arrest during cardiothoracic surgery in children. I should say cardiothoracic surgery. And in fact, in the 2007 data, it was the top cause of cardiac arrest during cardiac surgery in congenital heart lesions in children. And we do know that massive transfusion protocols themselves can improve survival and reduce rates of post-trauma complications in trauma patients. So there's reason to believe they're good things. And our hospital has a number of these major hemorrhage experiences every year, a total of about 17 a year. That includes both the adult and the children's side. And we know that coordination is key to treating these situations well. So coordination between blood bank, clinical areas and quarters as well. And we knew that there was a need to improve this. We could see that clinically. This started many years ago, and we used in-situ sim to identify the latent threats that we were seeing on the clinical basis. And we've actually published, I'm afraid the reference hasn't quite come out, but we've published some evidence showing that that in-situ sim is very valuable in picking up additional latent threats that are not necessarily shown by patient safety incident reporting. We know that repeated simulations allow iterative quality improvement and analysis of human factors, which can help make us a safer ward. So I'm going to talk to you about our in-situ major hemorrhage simulations. So these were 9 simulations taking place between 2012 and 2018. Very big simulations to organise and put on, needing coordination between PICU, blood bank and the porterage service. We used a PDSA tool to the massive blood loss guideline and checklists to check our adherence to the guideline and to get some data about the start of transfusing the first unit of blood, cross-matched blood, and also participants' confidence. And this is just a nice photo of one of the simulations. So you can get a feel for that there for the high fidelity of the situation and you know the energy in the room that there would have been at that time. And just in the background, you can see somebody with a yellow badge that's making some notes that is writing down some data for us to analyse. So we ran these different simulations, 9 different simulations, and we identified latent threats, which we analysed and then treated with quality improvement. And particularly, I'd like to say we made sure we had brainstorming sessions after every simulation. So we did the standard debrief, but then because it was such a big simulation, that had got so many learning points, it felt important to actually sit down with all the different teams and really clarify exactly what all the learning points were that each department felt that they could note from that simulation. And this would have included simulation fellow, teamatology, consultant or transfusion nurse, the resource leads, and the portering service as well. And as part of this, we found it very powerful to do video filming, and this really helped us to analyse work as done rather than work as imagined. So I'm going to show you.
Okay, I see you. Yeah, the blood is already in the initial fridge? Okay, thank you.
So this is on one of the first simulations that we ran, what happened when the nurse went down from PICU, the runner, to try and collect the emergency blood. So in the simulation, the patient is hosing blood out. Everyone upstairs is very panicked, quick, going to get the blood, and the nurse runner has come down to collect the blood. So she has to swipe into that machine. But unfortunately, the lab staff realised that the wrong blood had actually been collected. This actually happened in our simulation and was caught on video. So as you can see, this was a major latent threat. I mean, the amount of mental workload to have to try and work that blood bank issuing system whilst you're feeling very stressed about a major hemorrhage is huge. So we came up with an improved protocol. The lab staff would prepare the blood and hand it over directly, having checked it themselves. And this then took only 11 seconds as opposed to the 1 minute in the previous system. And in fact, previously it took 2 minutes because they had to do it again because they did it wrong the first time. So in terms of our results, so over the 9 sprint simulations, we had 74 participants. I'm not going to go through the increased confidence data, but we did show increased confidence. And participants felt the scenario was realistic and had a high stress level, similar to real life. So I'm just going to talk a little bit now about the different latent threats. So 19 latent threats, 8 significant QI projects, and we categorise them as patient safety, which I'll pick out some key ones here. Patient safety, efficiency and reduction of waste. So patient safety, so I mean this was the one that I have just shown you in the video, and this was a huge patient safety improvement. I mean, some simple things. Until we did the simulation, no one really realised that the blood bank didn't have a cordless phone. So when people came to blood bank, they were struggling to be on the phone to the ward and try and open the door to people coming to ask for emergency blood. There's an outlying ward at the Brompton over the road because of our old-fashioned setup with different buildings, and that needed to be changed so that we could actually get in there at night. Communication was a major area. There was found to be difficulty contacting PICU consultants and consultant cardiothoracic surgeons. We didn't get a cardiologist when we need one, and even contacting blood bank was difficult. So we had a different category for the Major Haemorrhage 2222, which I believe is now fairly standard across the UK, but that was new to us at the time, some years ago. And we also now have a mobile phone which the PICU nurse in charge carries at all times, and that's a baton phone passed between the different nurse in charge each shift. And that has all of the mobile phone numbers of PICU consultants and cardiothoracic surgeons and any other useful people who might be in there as well. And blood transfusion also then had a bleep allocated as well. In terms of equipment, we found there was some problems with the chest opening trolley for these emergency restenotomy procedures. There were some things that had been stopped wrongly or weren't labelled correctly, and that they were fairly simple things to fix. There was a suction unit not working, again, simple to fix, but simulation was the thing that we needed to do to uncover that latent threat. And then here's some problems leading to efficiency issues. So there was difficulty contacting the blood bank, I've talked about that. And also the original protocol required the porters to bring emergency blood, and sometimes they just would be busy and they wouldn't actually attend the emergency. So the newest protocol iteration is now that the PICU nurse in charge is able to get emergency blood out of a fridge that's actually on PICU itself, and she will take it to any crash around the hospital, whether it's in a different building or anywhere else. We also found that electronic requesting was too slow, and actually paper cross-match forms were more efficient in the emergency setting. And in terms of teaching and education, some staff were unaware of the MBL protocol, and the guidelines on which specific products to use were not always that obvious, so we have improved the guideline itself. And we did publish this, I won't go through all of this, but that's a reference which is relevant, showing that by iteratively doing these PDSA cycles, we improved the chances of having a simulated CBL without any latent threats as time went on. And we improved our time for emergency blood to be administered from 6¼ minutes down to 2 minutes, which is a reduction of 2/3 and is highly clinically significant. It's not so easy to do statistics on that, but I'm sure if it was your child, you'd rather the emergency blood got there in 2 minutes rather than 6½ minutes. And this is our current protocol, which I won't go through in detail, but it's on one side has this layout to show what each different department should be doing, and on the other side has got the more details of which exact units we should be giving of what, when. So the challenges. So the main challenge for this entire project was getting buy-in from the management of the hospital to really put in place these changes. And the main problem itself with that was that the management staff had quite high turnover. So we'd have got, the lead for resus and the safety lead for the trust to be fully on board, and then they would change posts and it would be somebody else in post who wouldn't have been with the sprint program on that journey through all of these different simulations and all of our findings. And because the bureaucracy just took such a long time, we are still, even now, after 7 years, in the process of fully implementing our changes that we want to make, with a full implementation date now of the end of January next year. And it'll only be from that date that we really have our PICU emergency blood for the nurses to take to be fully staffed. So in conclusion, our sprint training has picked up 19 latent threats. We've had multiple QIM improvements and overhauled our algorithm. And we've led to an improved time for supply of emergency blood. So if you have any questions, I'd be very happy to take them.